So today I'm going to tell you about the basic interpretation of an IOPR, that is an intraoral periapical radiograph. So I think we all are aware of this small radiograph which we make in almost every patient to diagnose a particular pathology associated with a tooth. So this is again an intraoral periapical radiograph of a mandibular posterior region which is showing premolars and a molar. So this is basically focused on the premolar. This is tooth number 5. Okay. So whenever we are interpreting, we have to tell that this is what type of a radiograph, how we have taken this radiograph, how we have made the patient sit on the chair, how we have angulated the tube head. Okay. So, and how we have placed the film, all those details you can write. You also can make a mention of that how much amount of exposure, how much amount of milliamperes of current, and how much amount of voltage has been kept to take this radiograph. After telling all these details, we come to the normal anatomical landmarks. So whatever normal anatomical landmarks you can see on a particular radiograph, you have to make a mention of that. So in this particular radiograph, you can see this radiolucent line or a linear radiolucency, which is suggestive of an inferior alveolar nerve canal, which is an important landmark in the mandibular posterior region. So once we've written all the normal anatomical landmarks, we have to tell about the pathologies associated with the teeth. So like we can see here, as such, we don't find any radiolucency. That is, we don't find any black area in the crown structure. Okay. So we don't find any radiolucency. We just can see a radiopacity in relation to the 5. So first we will talk about the crown of the tooth. So like in this particular radiograph, the number 5 is a focus. So I would say that if I just see a crown structure, I can just see this hyperdensity within the coronal pulp chamber, which is suggestive of a obturating material. So once we are done with the crown structures, we have evaluated all the crowns. Likewise, you also can have a caries, and that can represent as a hypodensity in the crown structure. So once you're done with the explanation regarding the crown structure, you can come to the radicular part of your tooth, which is your root. Now in the root, we can see in this number 5 tooth that we can see a hyperdensity within the pulp canal, which is again suggestive of an endodontic obturating material. Like we can see in the 6, we can just see the normal pulp canal. So we'll just make a mention that we can see a normal anatomical tooth, or we just see a normal pulp canal associated with 6. But if you just compare it with the adjacent tooth, you can see a hyperdensity within this, which is suggestive of an endodontic obturating material. So once we are done with the radicular aspect, we have to see to another important landmarks which are present in the bone. So we have a opaque line which is surrounding the root of the tooth, which is called as the lamina dura. So we have to see the continuity of the lamina dura. As you can see in this tooth, we cannot see that radiopaque line along the root of the tooth, which is missing. Also, we can see that pedial space is widened, and we can see a well-defined pathology in the alveolar bone. You can see here, we can see a well-defined area of hypodensity, again with the non-corticated borders. So this is mostly suggestive of an infected radicular cyst in relation to this tooth number 5. So how we have come to a diagnosis of infected radicular cyst? As we can see, the lesion is, or I would say this hypodensity is quite large. It is more than 1 centimeter in size, and also we don't find any cortication along the lesion. So that is suggestive of an infected radicular cyst. So this is how we come to a diagnosis of an infected radicular cyst associated with an endodontically treated 5. So once we have completed the radiographic diagnosis, we have to see the faults. As such, I cannot see any radiographic fault in this, but you might have a fault that you need to report, that whether it's a cone cut, whether it's a shortening of the teeth, whether it is elongation. So you have to make a mention of the radiographic impression and also the radiographic faults associated with IOPR. So this is how we basically interpret a IOPR. And likewise, we have the other pathologies, we have some other lesions which you can actually capture on a intraoral periapical radiograph. Thank you.